call this meeting to order. Agenda item number 1 are the minutes. Included in your packets are copies of the minutes from the November 20th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval.
So moved.
Second? Is there any discussion? All in favor? Aye. Any opposed? Minutes are approved. Commissioners, you've received the written updates from our centers. Ben, do you or any center directors have anything you'd like to add?
Thank you, Mr. Chairman. This is just a broader announcement that many of you already know that on Tuesday, CMS announced the award of 11 SIM model testing grants. Maryland, we had already known, was not a winner of the testing grant, but we did receive an additional $2.5 million for SIM development activities. The Commission, as you know, worked very closely with the Department in the development of the previous SIM application, and we expect to work with the Department moving forward with what I would expect would be a somewhat narrower application that might focus on the Medicaid dual eligible population. We have not yet begun discussions, but we will continue to think that some of our ideas, particularly as it relates to provider performance, enhancement of practices, EHR capabilities, would be consistent with a delivery system reform that focused on the Medicare, Medicaid dual population.
Thanks, Ben. Any other centers?
We've talked a lot about the new website. I just wanted to update you all on what the staff has been doing over the past several weeks. You're aware of the press release that was issued in December 2nd. There were 2 articles that appeared, the Baltimore Sun and the Washington Business Journal. Then, of course, Ben was interviewed by Josie Sturman, ABC News Channel 7, on the 12th, and we received quite a few hits after that, the airing of that news story. We're up to about a little over 900 visits to our website. We've also established links and partnerships with certain organizations. ARC has included the new website in their recent newsletter. It was put out earlier this week. They announced that we are a user of Monarch. We're the first state to use Monarch 5, which is the new version that we've incorporated, and one of 13 states that uses the software for public reporting. We've also tailored a piece of news information for the CDC NHSN newsletter, and that was tailored to the progress that the state has made, that Maryland hospitals have made in the vaccination rate. It's now up to a little over 97%. And I should also say that Maryland now is the #1 state in terms of vaccinating all employees, healthcare personnel. So that was great. And that was issued in the September 17th edition of the CDC Comorbidity and Mortality Weekly Report. The CLABSI rate, of course, is now down by 60% since we first started. And MHA and the Maryland Patient Safety Center have linked to our website, and MHA has agreed to request that all hospitals link to our website on their website. We've worked with consumer advocacy groups, 2 in particular, Healthcare for All, and they have agreed to distribute the website to their social media, both Twitter and Facebook, and that's close to 5,000 visitors to those. And they've also agreed to promote the website when they host their regional forums they'll be doing between January and June of next year as part of the consumer engagement project with HSCRC. And then the consumer advocacy group named the Women's Coalition for Healthcare Reform has issued a press release, included our website in their newsletter, and we've outreach to the Consumer Union, and Lynn Quincy of the Consumer Union has agreed to review the site and to give us feedback. So we're very encouraged by that. I just wanted to provide that update. We'll continue to promote as much as we can and give you updates. Thank you.
Thank you. Strong work.
Thank you. I wanted to alert the Commission that early in 2015, we're going to start work on updating our home health regulations in the State Health Plan. These were last updated in 2007, so they're definitely due for an update. Our long-term care division, Linda Cole and Kathy Weiss, are putting the finishing touches on a white paper that explores the issues in home health and how and what ideas we have in terms of reforming CON regulation in this area. And we're also putting together a work group that we're going to use for feedback and developmental work on the update, starting with the white paper. So we're putting that group together, and of course it's fairly easy to get people from the home health industry on that group. We have a representative from a residential service agency, which is where we often see new home health agencies emerging. We have folks from the Department of Health and Mental Hygiene who will participate on that group. We have someone at CMS who's agreed to kind of follow along with the work of that group and serve as a consultant for us. But we are certainly interested in any willingness by a commissioner to actually serve on that group if someone has a particular interest and is willing to make a bit of a time commitment for that. And of course, we're also looking for a consumer. We haven't nailed that down yet, so if you have some recommendations, we'd be very happy to learn of any recommendations you have for a consumer representative on that group. Thank you.
Thanks, Paul. I guess you're here for.
Quick question, Paul. On the when you say that representatives from the industry, I want to be sure that that includes some non-traditional home health providers. And what I'm thinking of are local health departments in some part of the state are actually certified home health providers in the traditional sense. But more broadly, the concept of home health, I think, is really broadening, and community-based post-discharge services delivered by a new constellation of workers is emerging. So I think that this is, if we're going to do a chapter update, which it sounds like worth doing on home health, I think we need to be thinking, kind of modernize the idea of home health to include the traditional, but also to look at some very important innovations in care delivery outside a clinical setting. So specifically local health departments, but there are also care coordinators who are clinicians, licensed clinicians, who work for nonprofits such as Health Access Maryland, HCAM, for example. So just to think more broadly in terms of representation on that work group would be a suggestion.
Okay, thank you. We'll take that suggestion in hand, and we're putting together the group, so we'll look at that.
Paul, I think you're here for the next agenda, aren't you?
Any more updates?
No.
All right.
Okay. So Eileen and Paul are going to present staff's recommendations on 2 hospital applications for certificates of conformance to establish elective PCI services. The 2 hospitals seeking approval are Carroll County Hospital Center and University of Maryland Upper Chesapeake Medical Center, which currently provide emergency PCI services. After the presentation, the Commission will take action separately on each hospital action.
Thank you, Mr. Chairman, members of the Commission. So after over 2 years of very hard work legislatively and on regulations, most of which was done by Eileen Fleck here on my right, we are today at a point where we're actually going to use this new state health plan that we developed for cardiac surgery and PCI, and which you adopted as final regulations in August of this year. So we have before us our first 2 applicants for certificates of conformance. This is a new regulatory model that was purposely developed to parallel traditional certificate of need review. The idea was for certificates of conformance, which are really the vehicle for regulating PCI in Maryland. We have a more streamlined process, and hopefully we've accomplished that with, I hope the applicants will agree, and I think staff agrees that it's a little more streamlined than certificate of need. Just to give you a little bit of the background here, which is also in the beginning of your report. And in terms of streamlining, you'll notice we did do one report on both applications. We now have a total of 23 hospitals that provide PCI. 10 of those are cardiac surgery hospitals, so they provide the full gamut of PCI, and those are still the settings for about 70% of the total PCI cases that are done in the state. We have 8 hospitals that are not cardiac surgery hospitals but are approved to provide both elective and emergency PCI. And we have 5 remaining hospitals in the state, and 2 of them are before us today, that are only authorized to provide emergency PCI. And Carroll Hospital Center and the University of Chesapeake Medical Center, Upper Chesapeake, University of Maryland, Upper Chesapeake Medical Center are here today seeking approval to add elective PCI. They've both provided primary PCI since 2008, and they've done a good job based on the renewals of their waivers to provide primary PCI outside of the cardiac surgery hospital setting. I think they've all received, after their initial approval for 1 year, they've now actually all received, they've both received 3 2-year renewals of their waivers. So they've been able to demonstrate that they've met our applicable criteria for primary PCI, and now want to add elective PCI to that mix. These are both facilities that are in the north central part of the state. In the case of Carroll Hospital Center in Westminster, approximately 30 miles from the nearest alternative site for PCI. Bel Air in Harford County, which is where Upper Chesapeake Medical Center is located, is a little bit closer to alternatives, more like 19 to 20 miles in their case. Both of these are located in jurisdictions that have a population base which, based on our experience, would indicate that they can probably reach the minimum volumes that we would like them to reach in order to be a provider of both elective and emergency PCI. Just to give you some comparison there, Harford County is somewhat larger than Frederick County. Frederick County is one of our 8 hospitals that provide both elective PCI and emergency PCI, and it is now doing over 300 PCI cases per year. Carroll County, probably their closest analog we have there is Washington County and Meritus Medical Center. Carroll County has about 20,000 more population than Washington County, and similar in that the alternative, Westminster is about 30 miles from an alternative PCI site. Hagerstown is about 30 miles from Frederick, the nearest alternative. And Meritus Medical Center in Washington County in the most recent fiscal year is doing about 300 PCI cases per year. So I'll turn it over to Eileen now, and she'll actually start talking about the review criteria.
Well, actually, before looking at compliance with the specific Certificate of Conformance standards for elective PCI of the State Health Plan, we did look at whether the 2 hospitals had continued to comply with the requirements for primary PCI services. Both hospitals did obtain 2-year waivers to provide emergency PCI services in 2013, and both demonstrated that they continue to meet the staffing and performance standards for emergency PCI services, including an acceptable door-to-balloon time, assuring that most heart attack patients are receiving services on a timely basis. At Carroll Hospital Center, 88% of the STEMI patients received primary PCI services within the door-to-balloon time standard for fiscal year 2014. And for Upper Chesapeake Medical Center, in 78% of its emergency PCI patients received services within the 90-minute target. We also examined the compliance of these hospitals with the general standards for charity care, quality of care, and information regarding charges that are applied to all hospitals that are applying for a certificate of need. And we found that both hospitals comply with those standards. And finally, both hospitals complied with State Health Plan's program policies for consideration of new elective PCI services, which is that they have been providing primary PCI services for at least 2 years.
So when we look at the specific review standards for elective PCI for a certificate of conformance, both of these hospitals have agreed to voluntarily relinquish their authority to provide elective PCI if they fail to stay in compliance with the performance standards, the applicable performance standard. On the need review standard, this is probably the one that that gave us the most pause and generated the most discussion in our review. That need standard is a simple sentence. The hospital shall demonstrate that its proposed elective PCI program is needed to preserve timely access to emergency PCI services for the population to be served. Both of these applicants, if you've reviewed the report, indicated that they believe they are currently covering their cost just with elective PCI. Primary PCI, I'm sorry. Thank you, Eileen. And I don't know that that was that unexpected for Upper Chesapeake. They've got a pretty high volume of emergency PCI. They're approaching 150 cases per year. We were a little surprised, I think in the case of Carroll, certainly, that they were estimating that they were covering their cost in the way that they accounted for revenues and expenses. So from the perspective of just financial viability, if you look at it that way, you might suggest that might indicate that, well, they'll probably continue to provide primary PCI even if we don't let them expand and provide elective PCI. But I think both of these applicants in this case made pretty effective arguments about the fact that over time this would become less and less sustainable. We now have 18 hospitals in the state that provide both elective and emergency PCI. There are clear advantages in terms of trying to reduce your fixed cost if you can have your cardiologist, who have to be on standby all the time to have a primary PCI program, if they can do scheduled PCIs at the same time. And there's also real advantages in terms of having cardiac cath lab facilities where you can do a diagnostic cardiac catheterization, and then if there is a need for a PCI procedure, they can proceed on an elective basis to also do that procedure at the same time, rather than having to stop after the diagnostic procedure and transfer the patient, refer the patient to another hospital. So on that basis, we felt that we should find that both of these hospitals have adequately demonstrated a need to have elective PCI in order to preserve their ability to serve as emergency PCI centers. And given their location, if we did lose these sites for emergency PCI, that would put a significant number of people at a distance from available alternatives that we probably would not be able to achieve a good timely PCI, a good timely intervention in the case of heart attacks, which is what that's what this is all about. Is the science indicated that we could proliferate primary PCI, which is the standard of care for STEMIs, and we're looking to augment the benefits we're getting with greater access to emergency PCI by allowing, where we can, elective PCI to also occur at these sites. Volume, again, the experience of our other non-cardiac surgery centers would certainly suggest that these hospitals can reach 200. In the case of Upper Chesapeake, as I mentioned, they're already around 150 with primary PCI, so they don't actually have too far to go to meet the minimum volume requirement. And in the case of Carroll, we think they used reasonable assumptions about their ability to penetrate the elective PCI market in their service area to reach that level of total case volume. Financial viability isn't actually an issue that's directly applicable here. We think both of these programs will be financially viable. As I indicated, both of them believe they're actually covering their cost for primary PCI now. But in our Certificate of Conformance standards, this is really a standard that applies to facilities that are seeking a waiver from the volume standard in order to be financially viable through the addition of elective PCI. As I mentioned, we think both of these applicants have demonstrated that they're high-quality providers of primary PCI, and they're worthy of the Certificate of Conformance on that basis. There's a preference standard that doesn't really apply in this case. And as far as patient selection, both of the hospitals have committed to continue to appropriately select patients for PCI procedures, and they're only going to be doing procedures based on the guidelines of the American College of Cardiology, American Heart Association guidelines, and the SCI guidelines, which have been adopted by reference in our state health plan. So patients who are at high procedural risk will be transferred to facilities that have cardiac surgery available. So on that basis, we are recommending, and procedurally we'll take these up individually, we are recommending that you approve certificates of conformance for both of these hospitals to provide elective PCI. I am told that we do have representatives from both of the facilities here, and I'd like to mention them. For Carroll Hospital Center, I've been told that Robert White, the Vice President for Operations, Chris Coleman, the Vice President for Finance, Jim Ridge, Executive Director of Cardiovascular Services, Tony Pinson, Manager of Cardiovascular Services, and Teresa Fletcher, Director of Business Development, are here with us today. And from Upper Chesapeake Medical Center, Mark Lewis, Director of the Heart and Vascular Institute, and Joy Hoover, Director of Planning.
Perfect. Thanks, Paul and Eileen. I'll take these one at a time. Can I get a motion to approve the Certificate of Conformance for elective PCI services for Carroll Hospital Center? Second? Any questions or discussion? No? Garrett?
Paul or Eileen, I saw in terms of the population growing in those areas, in terms of, I think I read something like 25% they predicted they would get that are going out of that county now or going to the hospitals now. I think that number's low, and they could actually capture a higher number. And I wonder if there's any experience from other hospitals that did the same process, captured a bigger population that can go locally rather than drive 30 miles away.
My review of the need assessment approach that both of these applicants used, their assumptions about the market share they would capture in their local area, and comparing that with the experience of the 8 other hospitals that started out as primary PCI centers but were approved, essentially grandfathered in the 2012 legislation to continue as elective PCI providers as well, because they were the participants in the clinical trials. It suggests that both of these estimates have been fairly conservative. Carroll is projecting between 206 and 230 total PCI cases in its first 2 years of operation. The experience, as I said, the closest analog is probably Meritus Medical Center, would suggest that they can probably exceed that case volume. In the case of Upper Chesapeake Medical Center, they're projecting, I think rightly, a greater number of cases, 250 to slightly over 300 in the first 2 years of operation. And again, given the size of their market, we think those are very reasonable.
Okay, good. Thank you.
Other questions or comments? All in favor?
Aye.
Any opposed? You have your Certificate of Conformance. Can I get a motion to approve the Certificate of Conformance for Elective PCI Services for the University of Maryland, Upper Chesapeake Medical Center? So moved. Second? Okay. Any questions or comments? All in favor?
Aye.
Any opposed? Motion carries.
So before we...
And who is on the phone?
Glenn Schneider.
Okay, there we go, Glenn. Sorry we missed you before. Okay,
No problem.
good to have you. Okay. All right, let's move on to agenda item number 4, where Eileen and Paul will present a preview of a report on the operation, use, and financial performance of freestanding medical facilities. The full report will be issued shortly after the beginning of the new year and will be considered for approval by the Commission in January.
Thank you again. Freestanding medical facilities are the newest type of medical facility created in Maryland. These were established in 2005, and the legislature, in establishing this type of facility, also established 2 pilot facility projects. And the first is Adventist Healthcare's Germantown Emergency Center in Germantown. It was established in 2006. And then the University of Maryland Medical System established the Queen Anne's Emergency Center on the Eastern Shore. I believe that opened in 2010. And we have a third facility which actually has been around for a long time, since 1979, the Bowie Health Center. And that's part of the Dimensions Health System. And it was, in some ways, kind of the original pilot without an appropriate license to go with it. So it was essentially operated under the license of Prince George's Hospital Center, its parent hospital, as a satellite emergency facility. Not totally in conformance with all of the regulations that have been established since with the actual category of freestanding medical facility, but that was pulled under this license after this licensure category was created. So it's also officially a freestanding medical facility, but certainly different in some ways from the 2 pilot projects that we're looking at. So beginning in 2015, we will have an opportunity to actually regulate these facilities under Certificate of Need. There's a prohibition on the Commission establishing any new facilities or DHMH licensing any new facilities until after July 1st of 2015. So in addition to finishing up this report and giving that to you to look at and officially approve next month, we will also be working in 2015 on developing state health plan regulations so we can actually start using Certificate of Need regulation to look at these. So freestanding medical facilities are, I think it's accurate to describe these as satellite emergency centers of hospitals. They can only be developed by general hospitals, and they're available to provide urgent or emergent medical care 24 hours a day, 7 days a week. I'll turn it over to Eileen at this point. She's going to run through a slideshow and at least give you a preview of the utilization and financing of these facilities that you'll be seeing in the full report shortly.
Thanks. So in this slide, I just wanted to show you what the trend has been in terms of hospital emergency department visits. Most of the increase in ED visits occurred between 1998 and 2008. The total number of visits actually increased 46%, so there was quite a big increase. And then, as you can see, it sort of flattened off around 2012, and it actually declined a little bit from 2013 to 2014 by 4.5%. And so right now we have about 2.5 million ED visits in hospitals for 2014. And so because of that strong growth in emergency department visits, the response to that was, hospitals looking at re-engineering their emergency department workflow. I think that was probably one of the biggest ones. But then also, expanding emergency department capacity at hospitals, and then developing urgent care centers adjacent to hospitals for maybe some of those visits where the acuity wasn't such that they really need to be in the emergency department. And then also developing hospital-affiliated freestanding medical facilities. For Bowie, obviously, it was developed way before then, so that certainly wasn't the impetus for it. I think with Germantown Emergency Center, that really was a factor that was driving the creation of that center and trying to reduce the pressure on Shady Grove Medical Center, which is the parent hospital affiliated with it. In terms of Queen Anne's Emergency Center, I think it wasn't so much the pressure from having a high number of visits. It was more concerns about access because of its location and being far away from hospitals with emergency departments in terms of the population served. And then traffic, I think, is an issue, which makes it a problem to get to some hospitals. And so, the first pilot project really opened in 2006. And since then, we've been asked to look at these facilities. In December of 2007, we issued a report on the operations, utilization, and financing of what was really just one pilot project at that time, which is Germantown Emergency Center. And then, in 2010, after it's been going a few more years, we issued a final report. And since then, legislation has passed that directed HSCRC to set rates for these freestanding centers. And so we were also asked now to look at what has been the impact of those rates. And then, as Paul mentioned, it was also back in 2010 that it was established that, okay, we're not going to have any more of these pilot projects, any more freestanding medical facilities until July 1st, 2015, and we're going to have it regulated through a Certificate of Need review. And so we'll be giving you the full report in January. This really is a very brief look, I feel like, at a lot of the material that will be included in the report. But there will, of course, be some basic information included in terms of, the number of visits, how many of those visits result in admission to an acute care hospital, looking at when patients register there, what time of day they're showing up, the acuity of patients, the age of patients, and the payer mix. And then also there's quite a bit of comparative information in the report, which I don't really include today, in terms of looking at the parent hospital and the overlapping service areas and how these compare to each other and compare to other Maryland hospitals. The financial performance, of course, is a key component. And so I have included that here today. And then also what the implications are for regulatory policy, since we do want this to be something that hopefully can inform the Certificate of Need regulations going forward. So in terms of visits, on this slide I've shown the visits for each of the freestanding medical facilities. As you can see, Queen Anne's Emergency Center, it's much lower volume compared to the other two, and that's because, both that freestanding center and its parent hospital are located in an area where the population is more sparse, so that's not really surprising. In terms of the admissions, on this slide I combined the three freestanding medical facilities to show that, on average about 5.1% of the visits result in a referral and admission to an acute care hospital, compared to at hospitals, 14.8%. And so with the freestanding medical facilities, the range is like 3% at Queen Anne's Emergency Center and 6% for the most recent year for Bowie Health Center. And for hospitals, I was a little bit surprised when I saw this, but the range actually does go down to, I think, 3.6% at one hospital, Fort Washington Medical Center. And the high end is about 23% at the University of Maryland Medical Center. In terms of the pattern of arrivals, what you can see on this slide is that most of the visits happen in what we refer to as the evening or the night hours from 4 p.m. to midnight, over half the visits in both cases, and that really a relatively small percentage are overnight from midnight to 8 a.m. At Bowie Health Center and Queen Anne's Emergency Center, it's around 10%, say. Germantown Emergency Center, you do see actually quite a few more visits overnight, about 21%, but it is still a small proportion. Unfortunately, I don't have this information that, for hospitals. It's not something I can get from the discharge abstract, but I may be able to try, find something either in the literature or maybe talk to some of the parent hospitals to see if they're able to provide something about what times patients show up typically.
For clarification, when you do that, are you going to look at seasonal variation, or can you look at seasonal variation?
I could look at seasonal variation. I think that may be important, especially maybe more for like Queen Anne's County Emergency Center. But that is something that we could look at. Should I go back?
I'd like to back up just a very basic question. I noticed you go back and forth between referring to these as freestanding medical facilities, and yet one of the slides referred to it as a freestanding emergency facility. Could you give a two-sentence description of what is the scope of services that are provided at these? Is it just emergency care? Is there other care as well? Is it urgent care mix?
Well, I guess part of the problem is, in my mind, I think of them as a freestanding emergency department, which is maybe what a lot of people think of them as. But the specific wording in the regulations is these are freestanding medical facilities. That is like the official category. I think that these are supposed to be like it's 24/7. So in urgent care, it's not going to be available 24 hours a day. So that's probably like a key difference, and that's why it's seen more as being like an emergency department. Although obviously, like, you can't admit someone to a hospital because there isn't a hospital. You have to transfer them. So.
If I could just add, I don't know about the other two, but Queen Anne, I mean, the emergency sign on the highway there is like 40 feet high. Emergency.
Yeah, I'm not exactly sure who came up with the name freestanding medical facility for the actual license itself. I mean, could you come up with a more generic name that really doesn't tell you much about what the facility is? So both of our pilots call themselves emergency centers, and that's legitimate. What they are not allowed under law to call themselves are emergency rooms, emergency departments, or hospitals. Okay. But they can call themselves emergency centers, and that's what they call themselves.
And can you comment on any intent of acuity differences between the freestanding facilities and the classic emergency room?
Right. I mean, it definitely is a lower acuity patient mix. So, I mean, you can see that just in terms of like the referrals who gets admitted. But then also there is a CPT code. And so I didn't include this in the slides here, but it will be in the report. There are 5 levels. And so what you'll see is that there are many fewer visits at the highest acuity level for these freestanding departments. I also want to, I probably should make the point, like, some people do see the potential for an urgent care center maybe to handle a lot of these visits. And so that is also why it's important to look at the time of day, because those urgent care centers are open typically maybe like 8 a.m. all the way to 11 p.m. And so if there aren't a lot of people showing up in those overnight hours, then maybe that's something to think about in terms of what need is it really serving.
Can I just say, I live and I work with the Queen Anne's one, and it's a fully stocked emergency department. I mean, it has CT scans, laboratory services, everything. So I mean, it's a little more robust than I think you're describing, at least in Queen Anne's County. I don't know about the other two, though.
Right. Yeah, they definitely are supposed to be like an emergency department in terms of the level of care and being 24/7.
So another just clarification. So is it likely or unlikely that a squad with the sirens running can show up at one of these places?
It does happen. I do have the mode of arrival. That's part of the data for the patients. A lot of them, as you might expect, are walk-ins, but there are some ambulance, people arriving by ambulance.
So it is somewhat semantic, this term. Someone can show up in a squad car with a really emergency, life-threatening, at one of these facilities. They've got to be able to handle it.
Well, yeah, and I think it's clear that this is another major distinction between this type of facility and what we usually call an urgent care center. There are patients transported to these facilities by ambulance. But like every ambulance transport, MIMS has established certain protocols for use by the EMS teams in the field. And so when you say ambulances are going to be arriving with people in life-threatening situations at these facilities. I think they're actually, the MIMS protocols are trying to actually avoid that. If it's clear that this person needs to go to a real hospital, for example, surgery might be required or something like that,
right? I mean,
or a heart attack victim, they're not going to stop at one of these facilities. They're going to go to the nearest hospital emergency room.
Okay. A couple questions for Ann.
Thank you, Diane, for opening up some more generic questions. Before we kind of get into so a little bit of background. First of all, on MIMS, I think it would be helpful when down the road to get an understanding of the protocol for priority, how EMS locally triages patients, which ones can go to a freestanding as opposed to those that MIMS suggests that the EMS transport to a full-blown hospital. I think that that's a good clinical distinction for us to understand. My question has to do with the governance. Are these have a parent hospital, so the board, the governance structure of each of these three is identical to the board of the parent hospital. Is that right? Or do they have their own governance?
I'd have to ask them and get back to you. Like, I'm not sure of how that works in terms of the governance. But I guess I would expect, because they are seen as like a subsidiary, that it would just be part of the governance for the hospital. But I'd have to ask.
So out of that comes some other kinds of community relations questions, such as hospitals are these also separately required to develop community health needs assessment plans, operate community benefit programs, those kinds of separate, in their local community, those separate kinds of obligations that are in effect with regard to hospitals. How is that carried out with these facilities? Is basically my question. And finally, are they subject to global budgets through the new waiver? And maybe you're going to get into that in the financing.
Well, I think on your first question, I do not think these are viewed as hospitals. They're viewed as satellite facilities with a parent hospital. So the community benefit obligation, community needs assessment, those are really requirements that are applicable to the hospital itself and not distinctly applicable to these. Even though they're separately licensed facilities, they are essentially viewed as appendages of a general hospital that has established the facility. And yes, as rate-regulated entities, just like hospitals, they are within the global budgets. In this case, there is a global budget for Adventist Healthcare, the two-hospital system, which also includes this freestanding medical facility, and this is part of that system. And there's a global budget for the University of Maryland Medical System, and the Queen Anne's Emergency Center is part of that global budget, and the Bowie Health Center is part of the global budget for dementia.
Thank you. Catherine?
I would just add that this is clearly a changing environment, and this concept of urgent care is probably shifting as we're speaking. So as you prepare it, you may want to line up some comparatives to see what's happening. As recently I've heard of many facilities moving into urgent care, and I was having a hard time differentiating emergency.
Yeah,
and so I think there's some plates of the earth are changing out there. So as we go forward, is to be more proactive in looking at that. And it may not require anything regulatory, but just be informed.
We recognize that that's an important thing to address in the report we're developing, kind of, where this fits in between the hospital universe of emergency medical services and these urgent care centers that have developed in various forms and are developing, some of which are being developed by hospitals as well. It's tricky because they're not regulated in any way in Maryland. These things that call themselves urgent care centers are just basically considered physician offices that stay open longer and take walk-ins. So it's not a data-rich environment that we have to work with in terms terms of understanding the urgent care center operation. But we're trying.
Barbara?
One quick question, clarification. Is this study with HSCRC or is it just an MHCC study?
It was assigned to MHCC, and we are to consult with HSCRC in doing the study. And this second study too was specifically, designed to take a look at kind of the before and after of rate regulation, because when these things were first established, they weren't rate regulated. That came along later.
That's what I was going to say. I thought that was probably mostly the point of this, especially with regard to the new waiver now. Do we want to see a proliferation of these kinds of facilities that are under the rate-setting system, given the new waiver and its requirements as compared to other facilities that are out in the community doing sort of the same thing that aren't on the street?
Right.
Okay. Ben?
And the answer might be, it depends.
Yeah. And just to let you know, in terms of a real before and after, as far as rate regulation, there's really only one of these where you can really look at that, and that's Germantown, as it operated for about 4 years without rate regulation, and then it's operated since 2011 with rate regulation. Bowie has always been rate regulated, although the way it's been rate regulated changed in 2011. And Queen Anne's didn't open until 2010. So it's been rate regulated through its entire existence. So there really isn't a before for them.
Rate regulation is really just uncompensated care as well.
That's a big difference, yes.
Okay. Seems like we got the foundational questions. Then we'll let you finish the presentation, and then we'll see another host of questions.
Okay. So on the slide, I have shown the payer mix by location. What you see is that at the freestanding facilities, there are many more Medicaid patients and many fewer Medicare patients compared to the hospitals. And, there's a range in terms of Germantown versus Queen Anne's Center, Bowie. But I think it's mostly, you can see that there's a difference in terms of those big payers. And then also, what I didn't show here on a slide is that I'll have in the report is that it is a younger population that's served in the freestanding medical facilities compared to the hospitals. So then I was going to just jump to the financial performance. And so, this for Germantown Emergency Center shows from 2007 to 2013, their revenue. What I've shown in red is what's being subtracted from the gross revenue. So like charity care, bad debt, and contractual adjustments. In red, those numbers get subtracted. And then I've got the net revenue line. And then maybe what's easiest to look at, there are a lot of numbers here, is just the income, which is, and it's probably hard to see if you're looking at the slides. But so the income in 2007, and these numbers are in thousands, so the income was a net loss of around $1 million, rounding up. In 2007, 2008, it was still a loss of about $850,000. 2009, it was a loss of about $1.5 million. 2010, they did a lot better. This is still before rate regulation. The loss was only was less than $200,000. 2011, the middle of 2011 is when rate regulation took effect, and that year they had a loss of about $350,000. 2012, it was less than $400,000. But then you look at 2013, and their loss is up to $1.9 million. So that was their worst year, but in 2009 they did have a year where they had a net loss of $1.5 million. So there is quite a range in financial performance here, before rate regulation and afterwards. And what you can see is in 2013 that the charity care really jumped up compared to 2012. It was nearly twice as much, and then also, bad debt. They had a fair amount of bad debt, although maybe not their worst year, but still worse compared to some of the other years, where, especially compared to the years where they did well. So, this is something where it wasn't a situation where clearly they were better off as a result of rate regulation. It doesn't guarantee that they're going to be able to financially stand on their own and not have a loss. should I pause on this
Keep going.
slide?
Just keep going.
I don't know. It's a lot of numbers. It might be hard to read. And so then on this slide, I just put together the per visit costs and revenue for recent years. So you can see that, the gross revenue per visit, it has gone down a little bit, but it didn't, decline a whole lot. The charity care did really go up in 2013, and bad debt was certainly a lot higher than in 2011. And so, their net revenue per case has gone down, and their expenses per case, continues to be about the same. And their income, as you would expect, based on what I just told you about 2013, per visit is significantly lower. They're losing, it looks like, $55 per visit. And so I've just created similar slides for the other facilities. So for Queen Anne's Emergency Center, it's had very big losses each year that it's been open. And because its number of visits is lower, that's probably not really surprising. It has, fewer visits to spread costs over. And so, its income in 2011 was a loss of about $2.2 million. And in 2012, it was still a loss of about $1.9 million. And then in 2013, they had their worst year with a net loss of $3.5 million. And so, again, I think it probably goes back to the visits where they just don't have the same volume that some of the other centers do. With Germantown Emergency Center, they were over, I think, 37,000 visits in 2014, and so that's really going to help in terms of controlling those expenses per visit. So in this slide, I've put the per visit costs. Their revenue, it might be hard to do the comparison since I don't have them side by side, but their gross revenue is lower than Germantown Emergency Center, so they're getting less revenue per visit. Their bad debt doesn't seem that bad, but if your expenses are still high per case, what you can see here is their expenses are much higher, over $500 per visit, compared to, I guess we could go back, like around $300, $350 at Germantown Emergency Center. And so, okay, now I've got Bowie Health Center. This one, what you'll notice is that, they also had a loss in 2012, about $500,000 on net, and then a loss of close to $1 million in 2013. But then in fiscal year 2014, they actually did have a profit and they were net $1.9 million. So that's quite a turnaround for them. Their total visits, it is similar to Germantown Emergency Center, and their gross revenue, it's really not that different. I think it might be a couple $1 million higher, but their net revenue was much higher in 2014 when they realized that profit. The other years, the net revenue was only like $8.6 million for 2012 and $9.8 million for 2013. So this is something where I think we still need to look into it a little bit more and maybe talk to HSERC more about this and talk to Bowie Health Center. I do know that I don't have this in the slides to show you, but the acuity of their patients was higher, like it was coded as being higher, and so with a higher acuity visit, I would expect probably they're getting more revenue because that's seen as a higher acuity case. So I think that is part of it, having higher acuity patients. And so here again, I just have the per visit costs and revenue, and again, like the gross revenue per case, it's not out of line with what you saw with the other two freestanding centers, and their expenses are a little bit lower, and so that obviously is going to help. And what you can see here is that although they had a loss of about $16 per visit in 2012, they were able to get up to, a net profit of $55 per visit in 2014. In terms of conclusions, I just have a few here. As I mentioned, obviously regulating payment for the freestanding medical facilities doesn't guarantee that they'll be financially self-sufficient. And then also, the freestanding medical facilities are serving a population that's less acute compared to the population served by emergency departments. And the establishment of Germantown Emergency Center did quickly reduce the volume of ED visits at Shady Grove Medical Center, and that reduction has been maintained over time. But for the Queen Anne's Emergency Center, there wasn't that similar, reduction in emergency visits for the parent hospital.
A couple of questions and comments. So on the financials, I mean, this commission doesn't normally look at financials in detail. That kind of next door's the group's purvey. And I guess when I see these financials, it's interesting to see them, but there's a lot of very important questions about what's actually happening in the interplay of contractual allowances, bad debt, and charity on the individual institutions, how they compare to that institution's practice on the emergency room, the parent facility, and then just in general accepted practice before you can reach any conclusion. So I'm like looking at that data and just wondering if we can make sure that it's really syndicated well with HSCRC before and really closely making sure that we're aligned around conclusions around that, because I feel like with this look, it's a bit hard to give guidance there, except to know that we need a few more points of perspective and context than just the individual financials to draw the conclusion. So that would be point one. And then the second point that I think was really interesting is the piece around volume and how volume interplays with the parent institution. And just you kind of brought out that conclusion, but understanding what is the difference between the cases that reduce volume at the parent institution and ones that don't. I think that would be important for our audiences to understand that. Those are two observations. Ben, what are you going to say?
Yeah, we will invite HSCRC to participate in the presentation in January. We sought for them to attend today. Happens to be their Christmas party, so I think it was a little unreasonable to get them. But I think, right, that's a perspective of the rate setters from the standpoint of how an institution might report losses in particular. Is important to get their experience because it does appear after rate regulation rolled in that in some instances charity care and bad debt did seem to increase, perhaps as a result of actual patient mix, perhaps as a result of better reporting. They certainly have an incentive to keep better tabs of this once the facility is rate regulated.
Other questions? Diane, and then Gary.
So an observation and then a question. When you first were going over the financials for Germantown and what you were saying, particularly talking about rate regulation going into play starting in 2011 and the net income being, appearing by 2013 to being significant, and just doing quick math, from 2007 to 2009, the losses were about $3,300. From 2011 to 2013, the total losses were about $2,600. So just at a glance is different than, looking at, and 3 points does not make a trend, I realize, but I guess the impression from your words left me in a different place than actually just doing some quick math on the bottom lines for those 3 years. Actually, there was less money lost after rate regulation. I'm not trying to be an expert on the financing piece, but just be careful to jump to conclusions unless there's some, deeper, almost statistical validation of, is there really a difference?
Yeah, I mean, unfortunately, like, because their fiscal year actually runs by the calendar year, I won't also have 2014. But I did hear from them that they thought it would be similar in terms of the financial performance with a really big loss in their fiscal year 2014.
So that leads me to my question, which is on just thinking about the charity care and the number of people who perhaps don't have insurance, and whether the increase the number of people on Medicaid with recent changes, whether that is a game changer in terms of what's happening in the market, and whether that might have an impact.
I thought HSCRC staff expected that because of that there would be less charity care and bad debt. And so that was a concern for them. And I think that influenced their decision about how much to recognize. Like, they make a decision about how much to recognize in terms of the bad debt and charity care going forward based on the past. And they felt like they shouldn't recognize it all in terms of factoring in for following years and the expectations.
I guess I'll make my question really simple. Does the increase in the number of people on Medicaid, it sounds like you're saying that they basically are in projecting what the loss would be or what the rate should be?
Well, they're projecting.
Don't give them credit for the charity care?
I guess how much credit they should give them, what they should recognize in their rates, right? So they want to, if they had a big loss or a small loss, whatever it is, they want to recognize that the following year so that they come closer to matching up with, okay, these were your costs, and this is what we should put into the rate so that you'll come out close to financially.
So they built into their assumptions that more people would be covered.
Yeah, like they have that. I just wanted to throw that in there. I know what you're saying in terms of, shouldn't this go down, right? Or you might, one would think, right?
Garrett. I guess my question is kind of similar. On page 2, the graph of ER visits, is that through January 1st, 14 or through year to date?
That's on a fiscal year basis. This comes from the HSCRC financial database, so it would be through June of 2014.
So do you think, and it's similar to what Diane was talking about, do you think the increase in the number of people, citizens in Maryland with insurance, dropped the ER visits? Now they have insurance, they can get preventive care, they can do things in the less likely, and I wonder if that's a national trend, or is that just Maryland?
I'm not sure in terms of the national trend. Sometimes it seems like there's a little bit more of a lag. Like, we have the data available, so I can quickly do 2014. But the national data, you know, what I've seen, it doesn't come quite, it doesn't, you know, immediately get to me. So I'm not sure about that one.
Yeah, I think that just keep in mind that inappropriate use of emergency departments is not isolated to the uninsured population, that it's endemic across all covered and uninsured populations. So I wouldn't necessarily expect drops to be automatically precipitous, and they're also dependent on what your primary care network in the community looks like. So if you have no inadequate primary care supply, even if everyone's covered, their usual source of care might be something like the
But with 18 years of increases, that's a pretty significant decrease just in the last year.
Right.
There's some reason for it.
Yeah,
right.
Great point. Barbara?
Just quickly, when we're understanding the business case for having one of these centers, can you look also at where people go for their follow-up care? Once they've been to the center one time, are they then in the network of the mother hospital for the doctors and the care that they receive, or do they go back to something else? I think it ties in with what Ben was saying about you don't have a lot of primary care out there, and you go to the centers when you have an emergency. Then if you need follow-up, are you going back to that center, or are you going to the mother hospital for the tests or whatever else you need?
Right. I can try and find out if the freestanding facilities have data, or the parent hospitals have information on that they can share with us.
That makes a good business case for why you would want to have a center.
Right. I mean, I thought expanding market share is actually frequently a reason for wanting to establish one of these.
Other questions? Comments? Thank you very much.
You're welcome.
Thank you.
So Just as in terms of follow-up, the report will be created over the next month. Actually, I've been told it's about 10 working days. We expect to have that to you approximately a week before the commission meeting on the 7th. On the 15th, that will put it around the 8th. And we would ask our colleagues at HSCRC to participate in the briefing. Although we like this two-phase approach, provide briefing, provide an overview of the report, and then have a shorter meeting on when the report is actually delivered. I think my expectation is that this might be a little longer presentation at the January meeting, as there are a lot of questions that need to be answered.
Thanks, Ben. We'll move on to the next agenda item. Srinivas and Aaron are going to review the results of the MRI self-referral study. If you recall, we went over this study in detail last month. Mary Jo Brates-Forbes presented the findings at the November Commission meeting. The report before you reflects the presentation from last month, and the scope is consistent with Chairman Hammond's letter and does not contain any recommendations regarding continuation or repeal of the Maryland self-referral law. We'll ultimately need an approval, and Srinivas and Aaron will focus on any differences since the last month.
Thank you, Mr. Chairman. We will go through this fairly quickly and see the findings last month. So I'm going to quickly go through the background of the study and any questions, and then Srinivas will go through the results and findings. There we go. Thank you. Usually I'm pretty good with this electronic. So just as background, Maryland's self-referral law and subsequent Court of Appeals decision prohibits non-radiological practices from owning an MRI, CT, and radiation therapy services in office. House Bill 536 of 2013 would have required a study of ordering of MRI services by non-radiology group practices that owned an MRI machine prior to the 2011 divestiture. The legislation did not pass. However, Chairman Hammond requested MHCC to study MRI ordering and utilization by these non-radiology group practices that did have to divest of their machines in 2011. MHCC awarded a small procurement contract to Braid-Forbes Health Research for the statistical analysis. So the two study questions were, did orthopedic practices that divested interest in MRI machines in 2011 change how often they ordered MRIs for their patients? And did practices that had a financial interest have different rates of ordering MRIs for their patients than similar practices for similar patients before and after their divestiture of financial interest?
All right, so as Aaron described, because the law was enacted in 2011 and the divestiture, rather not the law, but the divestiture occurred in 2011, the pre-post was set to 2010 and 2012, and so this analysis was conducted in that way. There were three groups. One was a case group, which were the specific practices that had to divest. There was one group of similar set of practices selected, and then sort of other orthopedists in Maryland. These were the three groups, the cases and two controls. There were patients attributed to each of these practices, and to do the analysis across the years, a difference in difference logistic regression was used and adjusted for some other relevant factors. We won't get into the details of the logistic regression in too much detail here. I think you had it probably last time, perhaps. It was too complicated. So we're trying to simplify it here. We're trying to make it a little bit simpler. So these have been conducted rather than the logistic regression outputs to odds ratios, which are probably a little bit easier to understand. And rather than give you the full thing, I'm showing you the three that are of interest in the study. So one is, was there a change over time? Was that specific to those the practices that had financial interest? Was that the financial interest in and of itself significant? And then, the sort of cases versus, that's cases versus controls and the financial interest. So those are the three that we were sort of looking at. So this is showing you for privately insured. So first, there was a very modest, reduced odds over this period of prescribing MRI. Now, all of these you'll see are not really some huge effects, so you should keep that in mind, whether you see a significance or not. And I would remind you that this is statistical significance, and whether that has a dramatic impact or not is a different matter. The second item here you see is for practices. In the regression itself, each practice was listed out separately, and so that's why you have a range shown here. But in this case, for the privately insured, there was indeed a difference between practices and the control groups. That is to say, they were higher before and higher afterwards. Okay, but you're seeing in the third row there is the financial interest. Did the ownership itself have an impact? And here what you're seeing is, well, that wasn't related to ownership. There was, whatever, they sort of stayed in parallel, if you will. They both increased or decreased or what have you, but the financial interest didn't play a role in that change. That's the take-home message out of this. And just to note, there were some other factors adjusted for in the regression, such as having high deductible plans and age of the patient. So a similar slide is shown here for you for Medicare patients. Here you didn't see much change over time, but the two main study questions, again, you see the same pattern. That is that the practices generally remained higher than the control groups before and after. I will note that there was actually one practice that had a reduction here, which is why you have a little bit of an oddity here of a 0.77 odds ratio. So that overall, most of them showed a higher trend. And then similarly, the financial interest in and of itself didn't have an impact on this change in time. So the take-home message here, relating back to the two study questions that Erin pointed out, one is that having a financial interest in and of itself did not seem to relate to the changes in MRI prescribing practice or utilization practices more accurately there. And however, we did find that the practice, the case practices, if you will, were higher before and remained higher afterwards in terms of their utilization level. So
if we try to get the talking points right, first somebody wanted the headline, it would be if you owned an MRI, you used it more, but then if you gave up ownership of it, it didn't tend to change your practice.
That's correct. That's correct. Yeah. I mean, and there's probably a variety of things that we did. This is a pretty short study period. It presumes sort of abrupt changes that you took it away and the next year there was change, and so most of the past studies have really looked not at the divestment side. They've looked at the addition of an MRI machine, and those have usually shown increased utilization. And whether maybe a farther lookout period might show you a different answer, perhaps more consistent with literature, but that wasn't the scope for this particular study.
Michael. You agree?
Thank you. First of all, thank you very much for simplifying the explanation, and for Dr. Tanio for recapping it in one sentence. A couple other things, though. I mean, it speaks nothing, obviously, to appropriateness of ordering or the patient mix in each of those practices. And so I think because this will be consumed by others who may not recognize those subtleties, I do want to make sure the limitations, those and others that we talked about at the prior meeting, are really well captured in whenever this is circulated. I don't feel, honestly, that they're adequately represented in the report that we're reviewing. Because I think this could be interpreted as, showing no effect, and that's contrary to the literature. And I think we do need to really express very explicitly some of the concerns that were raised in the prior commission meeting and sort of the implications that we're making here.
So practically, you would want that in an executive summary, that and with some of those caveats up front that I think is not actually in the report right now.
That's my sense.
There are probably you want more of an emphasis in the executive summary and not just.
But there are the limitations that are in here are appropriate. I'm just saying that there are probably some others that need to be addressed, and those were brought up in the last commission meeting. Appropriateness being one. The other is that practices that originally purchased or an MRI might have had a higher acuity and a practice pattern that supported and just because they lost the MRI doesn't mean their patient population changed. And so we don't really know if there, those and other questions could be easily raised, and I just am concerned about the, I wouldn't say misinterpretation, but interpretations that are not fully informed based upon the limited scope of this report.
So just as a process, some process information, if this report is approved, we will be sending it to the HGO committee, but we will attach a cover letter from the commission on top of the report that's in addition to the executive finding from the executive summary from our contractor, but really reflecting the conversations that happened at this commission meeting and the prior commission meeting.
Yeah, and I'm happy to practically circulate that ahead of time just to make sure we can get email input on that. Okay. Other questions? Okay. I think we need to formally approve the release of the report to the House Health and Government Operations Committee. Can I get a motion? Second? All in favor? Aye. Any opposed? Report is approved.
Thank you very much.
Bruce Kozlowski, Co-Director of the Center for Quality Measurement and Reporting, is going to provide background information regarding the Maryland Patient Safety Center, which the Commission has previously designated as Maryland's Patient Safety Center. After presentation, the Commission will take action on the staff recommendation to redesignate the Safety Center.
Mr. Chairman, members of the Commission, I bring with you today an action item related to redesignation, and I believe you all have a copy of the MOU that was produced as part of this process. However, before going forward, we felt a brief history of the center would be helpful, since it has been over a decade since enabling legislation was passed and the first designation of the center occurred by MHCC. Okay. What happened here? Okay, thank you. So the Patient Safety Act of 2001 required the MHCC to study the feasibility of developing a system for reducing incidences of preventable adverse medical events. The preliminary study produced in 2002 had a recommendation for a three-pronged approach. And then in 2003, the General Assembly, recognizing the importance, gave the Maryland Patient Safety Center, Inc. Medical Review Committee status, making records and files confidential and non-discoverable or admissible as evidence. Doing it again. Okay. The 2003 final study recommendations included the following. Creation of a patient safety center based on a VA model, a repository for voluntary reported adverse events, and educational activities to build consensus. Then there also was the promotion of a systematic change, and that was to occur in the data systems, advanced technologies, rate setting, and performance evaluation guides, and the certificate of need process. Revisions to hospital regulations were also addressed through revision of risk management regulations, standardization of definitions, reporting of sentinel events to the Office of Healthcare Quality, and root cause analysis of certain serious events by hospitals, nursing homes, and others. In the passage of the law, there was no funding provision. And so the HSCRC stepped up to the plate and agreed to provide funding to the Maryland Patient Safety Center. HSCRC agreed to do that through an increase in hospital rates. Then in October of 2003, the MHCC issued an RFP to operate the Safety Center and to reduce adverse events, educate health professionals, administrators, create staff as an advisory and Staff and Advisory Group and meet 8 semi-annual reporting criteria. In 2004, MHCC awards a no-cost 3-year contract with 2 option years to the Maryland Hospital Association and Delmarva. It was a collaborative initiative to bring this patient center forward. So in the first redesignation in 2009, MHCC received a report from the Maryland Patient Safety Center, Inc. on its last 5 years of activity. A notice was published on MHCC's website stating its intent to redesignate the MHA as the operator of the Safety Center and requesting public comment. No comments were received. MHCC redesignated the MHA as the operator of the Maryland Patient Safety Center in December of 2009. In September of 2014, the Maryland Patient Safety Center, Inc. presents to the Commission on past achievements and future plans. Then in October, again, MHCC sought public comment on the Patient Safety Center's performance. There were 7 comments, all positive. In November, MHCC creates a discussion draft outlining specific performance requirements. This was modified and served as the basis for the MOU that addresses the following responsibilities. Thank you. Operating plan, production of an operating plan that is updated annually, detailing current proposed collaborations, programs, and educational initiatives. Semi-annual reporting on proposed collaborations, prevention initiatives, programs and educational offerings, and progress since the last update, including relative statistics and trend data over the reportable time period by provider type, hospital, nursing home, etc., and reported event category, like falls. Each party agrees to exchange data that will enhance analysis and policy development. The Maryland Patient Safety Center, Inc. agrees to voluntarily share information on quality, except for the information held by Mid-Atlantic, which is the federal PSO. As seats become available on the Safety Center's Board of Directors, MHA may recommend for consideration a commissioner or a member of staff to serve on the board. The Patient Safety Center, Inc. agrees to give due consideration to the recommendation and share any concerns that it may have so that an alternative candidate can be recommended by the MHCC. If someone is selected, then the MHCC will participate as an ex officio, non-voting member of the Board of Directors. If a commissioner or staff member is not selected, the Maryland Patient Safety Center, Inc. will permit MHCC staff member to attend as an observer the portions of the board meeting that are related to the Patient Safety Center's directions and operations. Maryland Patient Safety Center, Inc. will seek comment and suggestions from MHCC on proposed funding priorities should there be a funding shortfall at some point in the future. Excellent. Based on all the discussions that have taken place to date and on the MOU, staff recommends that the Maryland Patient Safety Center, Inc. be redesignated as Maryland's Patient Safety Center, effective December 31, 2014 through December 31st, 2019. This is conditioned on the Maryland Patient Safety Center, Inc. remaining in good standing and designated as Maryland's Patient Safety Center, and that the MOU be executed as written. With us today is Robert Imhoff, President and CEO of the Maryland Patient Safety Center, Inc., who will assist in answering any questions that you may have.
Good afternoon.
Any questions or comments for Robert or Bruce? Barbara, and then Michael.
I had a few questions. The first, sorry. All right. Well, being older than dirt, I was around here when this first started, so I have some idea of what the knowledge, the concept was when we first started the Patient Safety Center. And I just wanted to be sure that as you're collecting the data and reporting, you mentioned nursing homes and ambulatory care facilities, which had been a concern of the Commission when you briefed us before. And I wanted to be clear that you were going to be collecting information from them as well.
Absolutely.
As a repository?
Yes.
And the information that you collect, one of the original concepts was to try to be preventative in collecting this information so that you would not only collect information on events that actually occurred that would be kept confidential, but the people, especially providers, would feel free to call you with near misses or things that they observed in practice that they thought could possibly result in an error at some later point, so that you could start to look if a bunch of people in a particular kind of facility started to say, we always confuse this kind of medication with that because we're arranging them alphabetically or whatever, that you would have something that you could send out an alert to other similar types of facilities to say, this appears to be happening and we want you to know about it for your future practice. Are you doing that kind of thing now?
We are not doing that now. That is part of the adverse event reporting system activities that we are trying to put together that I explained when we were talking about the when we made the presentation 2 months ago. Near misses are very much our intention to collect, to develop trends, to put out alerts, things like that. When we get this adverse event reporting system in place properly, we will be able to do that.
Because I think that would be huge in
Absolutely.
terms of impact.
I agree wholeheartedly.
And I guess the final thing is just the frustration that we talked about before, that when I read an article in the paper about an adverse event occurring somewhere, that this facility might be consulted or that facility for comment, but the Patient Safety Center isn't always out there giving the comments that I think that they should, or emphasizing to the public the role that you're playing. And that's a comment.
I am not in disagreement with you at all. So
I appreciate that.
Thank
you.
Thank you.
Thanks very much. And Commissioner McLean covered my first part, and I just want to echo the conversation we had previously about expanding or paying some more attention to the ambulatory care space, non-surgical ambulatory care, where patients get lots of care, and I know you've already voiced your commitment to that. But I was also looking at the members of the board of the Patient Safety. I wonder if you could comment on representation from ambulatory care, or practicing physicians on the board, or clinicians. I'll even be broader than physicians.
We have several clinicians on the board. I don't have the list right in front of me.
I see some physicians, but they look to be hospital-centric. So
we do have Ms. Hyatt, Andrea Hyatt, who's president of the Maryland Ambulatory Surgical Center Association. And then we have several nurses and several physicians on the board as clinical representation.
It would be nice to highlight, again, to represent sort of who's in the ambulatory space. Again, non-surgical. I'm talking about primary care, general, because that's, I think you're hearing a sentiment, at least from a few of us, that we'd like to see more representation of safety-related issues in the work of the Patient Safety Center in ambulatory non-surgical care.
And we strive to be very diverse in representation, both from an institutional standpoint and a practice standpoint.
Are there questions, comments, concerns? Brad?
It seems that most of the events that you're tracking are those that occur when the patient is in the facility, whether it's an ambulatory setting or inpatient. But as far as complications after a procedure, after a discharge, whether that's bleeding or infection, whether so that's post-discharge. So how do you receive that information? How do you collect that?
Right now, we're not collecting that at all.
Okay, so I didn't understand that. So if you're looking at an ambulatory setting, say an ambulatory surgical center, you're looking at the procedures during the patient stay there.
No, go ahead.
That's a couple hours, and then patients disperse.
We're not looking specifically at, we're not collecting data specifically right now from ambulatory surgical centers. The data that we are collecting is based on the programs that we are initiating right now. We are trying to put together the adverse event reporting system, which would which would detail adverse events and then near misses, and that we are intending to include that among the hospital provider community, the surgical center, ambulatory surgical centers, and the long-term care community.
So is a post-surgical infection an adverse event? I guess what I'm trying to understand, if that's the case, then we have a health information exchange. We have, through CRIS, a database that one could, in your position, in addition to reports from the facilities, post-discharge, you could monitor for certain codes and certain events. So I'm trying to see how you do your work, and I guess I'm getting a little ahead of where you are right now.
Yes, you are a bit ahead of where we are right now, and it's all the data we're collecting.
How soon are you going to get there?
With the
Okay, so like we got a lot of volume out there that's going ambulatory, and
it's been a slow progression, and again, we're trying to get this adverse event reporting system situation taken care of. In fact, I just had a discussion yesterday with Teresa and Steve Ports and Diane Feeney about our difficulties and our hurdles to accomplish that, and talking about ways to accomplish that. That's something that will take some time and will take some effort, pardon me, from a regulatory standpoint, if my suggestions are, or if we follow that route. To be collecting the data on the post-discharge is not something we are monitoring now. We certainly can begin to do that. We're looking for suggestions and looking for opportunities for other avenues, and we can certainly include that as we go forward.
I think that's important for ambulatory surgery.
I do appreciate that.
So I think the important condition in the MOU that I want to flag is that there was both organizations agreed to expand data sharing, and it may be that information the Commission holds can be shared through under a data sharing agreement with the Patient Safety Center that would facilitate those types of initiatives as well. So on the data sharing, subject to the Patient Safety Organization conditions which apply to the Mid-Atlantic Patient Safety Center, we saw information coming from the Maryland Patient Safety Center de-identified. But we would also be able to provide some information to the Patient Safety Center that would be helpful in that regard, and perhaps represent a efficient way for them to begin this type of monitoring, kickstarting, if you will, some of these initiatives.
And Robert, would it be okay if we try to create some kind of check-in mechanism like 6 months from now on those two pieces? Because it seems like that's the direction you're going.
Yes.
And I know that I think in general, the commissioners just need to have some structure to kind of make sure that those things are followed up.
Yes, we will make that a part of our semi-annual reporting.
That would be terrific. Okay.
Just very briefly, can you in a thumbnail say something about the challenge and the opportunity of the culture change that has to happen for this to work?
And when you say this, are you speaking specifically to the adverse event reporting?
Yeah, down at the level where it's happening, to be transparent and to change the culture, to actually report, not fear retribution.
Well, and I'll make it as thumbnail as possible. And I'm going to stand on a soapbox for a little bit, so you'll pardon me when I do that. The problem is not that the information is not being reported. All hospitals are reporting at the surgical centers. The problem is the way it's being reported, and to whom it's being reported. And I guess to whom it's being reported is probably the smaller issue, because there are technological ways, technological avenues to pursue to extract that information without additional cost or work by the institution that's reporting. So that is available. The real problem comes into play with how the information is being reported, in that it is there's no consistency and there's no standardization among the institutions reporting adverse events. that they are reporting adverse events within their organization to some entity that like RL Solutions or Quantros, whoever the adverse event reporting vendor is, and they're reporting it outside of the level 1s that go to OHCQ. They're reporting those adverse events for their benefit. And I'm not saying that in pejorative. They're reporting it so that they can see where they are and what they're doing within their organization, within their institution. The problem is when you have an organization like the Patient Safety Center that wants to take from the entire community, it is, right now, it is near impossible to distill that information down into any kind of trends or any kind of, to get a good look-see at what's going on within the provider community, within a specific provider community, because it's apples to oranges within all the organizations. So what I would hope to have happen in the future is that there be some establishment of some basic standardization and consistency among the reporting as a foundation for the reporting. Over and above that, if the organizations wanted to report additional for their own benefit to generate certain reports, we would certainly have no objection to that. But again, if there was some basic standardization, some basic consistency among all the institutions that we could extract this information and then look at these things and get regional and geographic trends, I think it would be beneficial to all, and that's what we're striving for.
Thank you. Michael and then Catherine. No, Catherine first. Yeah.
I just think it's important, and I don't see it in the report, that the Maryland Patient Safety Center become, in collaboration with, like the Armstrong Patient Safety Center at Hopkins, their methodologies and their designs, and so that there's some, if it exists, it doesn't come through in this report. Very sophisticated and very nationally known for its work on some of the issues that are barriers. So I think there's an opportunity there to be able to reach into some of our state expertise.
We are collaborating on a couple of projects with them. In fact, I had a conversation last week about a patient family-centered care initiative with the Armstrong Institute, and we're working on a second victim program now with them. So we certainly have a dialogue with the Armstrong Institute, and we can expand that, I'm sure.
And they're nationally respected for their methods and their design to be able to address some of these things. So it strengthens, I think, the position if some of that expertise were drawn into the justification, as well as really helping you, because this is not an easy initiative. You've got to have a lot of bench strength to be able to impact. So.
Thank you. Michael?
Well, first of all, thank you for your responses, but I'm going to direct my comments to Craig and Ben. I'm sensing a really keen interest among the commissioners in the patient safety in general, and I'm wondering at a time and format that's appropriate if we could make this a larger topic to discuss and see how the commission can support what's happening in all the spaces that patients receive their care. Because I hear a lot of ideas and suggestions, and I think there's a lot of energy behind this, and my personal opinion, it should be as weighted as heavily as we do with the quality reporting on hospital measures, those kinds of things. I'm not sensing that, at least we're at that same stage. Look at my colleagues to see if they feel that.
Yeah. Minutes should reflect the collective nod on that point. So, Diane?
So along those lines, Michael, I love the suggestion because as you talk about transparency and some foundational consistency and being able to show trends and change over time, there's certainly a number of examples around the country of states that do have a much more transparent approach to where the hospitals or various facilities are with their safety, patient safety issues. And it's not going to surprise anybody that when on the Patient Safety Board?
We, at this point, do not. I will tell you, however, we are in the midst of establishing a patient and Family-Centered Council for the Patient Safety Center. One of our new board members is Joanna Kaufman at the Institute for Patient and Family-Centered Care. I've asked Joanna to spearhead the formation of that council to bring patients and to bring family members, again, the consumer, the grassroots level, that they be a part of the process of the Maryland Patient Safety Center, leading to a board seat.
That's wonderful to hear. Joanna, being a nurse who does technical assistance for hospitals, I mean, she's a very well-respected woman and very knowledgeable, but isn't a patient or a family member. So I'm glad that there's a group, an effort to pull together a group with the intent to have patients on the board itself. I believe wholeheartedly in what many patient groups say, and that is nothing about us without us. So it would be nice to have them on the board.
And I will let you know that one of our fiscal 16 initiatives that is currently under study and being proposed is a patient family-centered care initiative. So we are taking a much more proactive approach in that area.
And I would just like to echo Diane's comments about looking around the country, because there are many states with much better quality indicators than the level that we have here in Maryland. So there's a lot to be learned out there from states like Colorado and Oregon, et cetera. So taking a look around, I think, will help us.
Okay. Can I get a motion to approve the redesignation of the Maryland Patient Safety Center, and to also that the MOU that you read was also executed as written, which has some provisions on the board? Okay. Any other questions or comments? All in favor? Aye. Any opposed? The motion carries. Yes, we are on agenda item number 7, which is around the assignment of benefits study results. Dr. Claudia Schur, the Vice President and Director of the Center for Health Research and Policy at Social and Scientific Systems, will present the study results of the assignment of benefits baseline report and will outline recommendations in the final report. Staff will present the final report at the January meeting so that that report can be submitted to the General Assembly shortly after January 15th. Dr. Schur?
Hello. Thank you for the opportunity to present these results. You may recall that I was here in October describing how we would approach the analysis. So I'll just backtrack just a little bit to remind you what this legislation was about. And it was a reaction to reports of very high patient out-of-pocket expenses, generally in hospital settings, for out-of-network care. And so the purpose of the legislation it primarily was to eliminate the balance billing of patients without having an adverse impact on out-of-network physicians. And so basically what the legislation did was to change how non-participating or out-of-network hospital-based and on-call physicians were reimbursed by non-HMO plans. Basically stipulated that patients who assign benefits to their providers would not be balance billed by those providers, and that carriers had two payment options in a sense. They could either pay the higher of two amounts, 140% of the average contract rate in the year prior or 2 years prior, and depending on whether it was hospital-based or on-call, there was a slightly different wording about being paid at kind of an average rate that they had paid, that the carrier had paid, that was inflated over time. And so the Commission has the responsibility for assessing the impact
of the legislation, and this is that analysis. The report is due in January, and you will have a chance to see that report soon, we hope, in a few weeks. But hopefully this will provide you an opportunity to see most of the results, and therefore the report will be hopefully an easy read. In terms of how we've approached this, the main data source are the medical care database claims from 2010 and 2013, so before and after. Fully insured physician claims, PPO, POS, and some other exclusions. So it's a fairly narrow look at one segment of the market. When I was here in October, we mentioned that we were kind of going back and forth with the carriers because we had expected to get an indicator on the 2013 claims, indicating whether particular claims were assigned or not. And we were able to resolve that, so we do have that AOB indicator on the 2013 claims, which you'll see in the analysis. We also look at Board of Physicians licensure survey data, and then we have some information from a sort of informal survey of the major carriers that was done. And so we're essentially looking at the impact of the legislation on three different groups, physicians, payers, and patients. And this is just a little bit of my caveat slide. Initially, we were focusing, and still are to a large extent, on out-of-network payment shares. So the amount of spending that goes for out-of-network versus in-network services. And if you look at that, in 2010, prior to AOB, and in 2013, post-AOB, there's a little bit, we just need to be careful of how we make that comparison. Essentially, in 2010, we assumed balance billing was allowed, which it was, and so we counted that, and that balance billing assumption makes out-of-network spending higher than it would be without balance billing. And so in a sense, if you compare the 2010 and 2013 and you assume balance billing in 2010 and not in 2013, there's just a little bit of skewing of results, or it just looks a little lopsided. At first, it's a little hard to understand why. And you'll see in the slides that we've sort of tried to present it in two different ways, just so it's the impact's a little bit clearer. And then the other thing I would say, just in terms of kind of a caveat, is that there's a lot going on both from the AOB legislation, but also just going on in the marketplace. So there's a lot of change. And so we're not necessarily attributing that change to the legislation. We're simply looking at the state of things in 2010 and then in 2013. There are a lot of changes going on which we don't really examine here that at the payer level. So when we present effects, it's from the payer perspective, but it's not from the individual payer perspective. And different payers are affected or act differently. And we're also trying to look a little bit at service level differences just to get away from that payment effect. So just this is the very broad brush, high level, before I make you go through all the detailed results, just so you'll know basically what we found and what to expect. Overall, from the patient perspective, we do see, as we would anticipate, a decline in financial burden. And I think that was the main purpose of the law, and we do see that. There is some variation by region in that effect, and it's likely driven by payer mix, which is different in the regions across the state. From the
provider perspective, the out-of-network share of payments, so the proportion of payments that providers are receiving from carriers, the out-of-network share has fallen, and similarly, the proportion of payments that they're getting from the patient from balance billing has fallen. And again, as I said, there's a very differential effect by payer, with networks expanding for some and contracting for others. And we'll basically be looking at the net effect. So here is the first look at the results, and I'll walk you through this, so try not to be overwhelmed by all those bars. And this is from the physician perspective. There's 4 sets of bars here, with the bottom set being the overall. Within each set, the darker turquoise, or the bottom bar, is shows the breakdown of total payments between in-network and out-of-network. The larger portion obviously being in-network. That's the blue portion, the light green portion being out-of-network. And then within the set, the bottom is 2010. Within each set, the top bar, the grayish, or I guess grayish bar, is 2013. The middle bar is that kind of alternative. So 2010 we show pre-AOB, 2013 post-AOB. The middle that's labeled 2013 alternative says, if we had assumed that balance billing was calculated the same way, or was sort of allowed in 2013, this is what the distribution of in-network versus out-of-network would look like. So it kind of holds that dollar weight constant. You can see, though, I mean, that aside, the important message here is that breakdown between in-network and out-of-network shares of total payments, and how it changed between 2010 and 2013. And you can see that the out-of-network share fell, and it fell a fair amount in 2010 from 20.8%, or about 21%, to 11% in 2013. And then if you look at, again, at these sets of bars, the largest impact is in the top set of bars. Those are the hospital-based specialties, hospital-based providers, where the out-of-network share of total payments fell from 27% to about 11 or 12%. And then you can see also on-call surgical specialties and on-call medical specialties, where the change was slightly smaller, but there still was a change. And you can see in that middle bar for each of the sets that the change is sort of muted if we make that alternative assumption. Okay, so one more look, and here you can just look at the words then, from the physician perspective. So across the affected providers, which again, the hospital-based providers and the on-call medical and surgical specialists, 79% of out-of-network services in 2013 were AOB, or had assigned benefits. So that's the vast majority. It's a little bit higher for hospital-based provider than for the on-call specialists, but still very, very substantial. And the proportion of out-of-network payments from balance billing fell from 21% to 6%. So those physicians that used to rely on balance, out-of-network providers who used to rely on balance billing, or rely on collecting part of their reimbursement from patients, are no longer having to rely on billing patients and hoping patients would pay that balance build part. Moving to the patient perspective, the proportion of users with at least one out-of-network service declined from 21% to 9%. So those are patients using any out-of-network services. We looked at that by both patient risk category and by Maryland region. The use of out-of-network services increases with risk category, so not very surprising. Sicker patients are more likely to use out-of-network services. But that increase, we see it in 2013, and there was a similar pattern in 2010. So no real change in that kind of relationship or distribution there. In terms of AOB or the assignment in 2013, 55 to 61% of services were assigned. That's the proportion of the out-of-network services that were AOB, and that did not really vary by risk category very much. Region is a slightly different picture. But again, the percent with out-of-network use, the percent of patients varies by region. The pattern of that variation was similar in 2010 and 2013. And then the proportion of out-of-network services that were assigned also varied by region in 2013. And again, I think that's likely driven by the mix of payers who vary in the proportion of providers that are out-of-network.
Acronym, NCA.
Oh, National Capital Area, sorry.
Thank you.
No. Okay, and then this next slide is also still from the patient perspective. These two bullets are sort of the same message. One is across all users, so including those who do not use out-of-network services. The second bullet is for users who use at least one out-of-network service. But in either case, what we're looking at is the average proportion of total payments that go to out-of-network services. And in both cases, that fell. Very different levels, but the proportion going for out-of-network care fell. And here we figured we'd throw in a chart every now and then just to change it up a little. These two pie charts, one for 2010, one for 2013, show the distribution of users by out-of-network share of spending. So the very large segment in both pie charts, that's kind of the dark purple, that is the proportion of users who did not use any out-of-network services. Very substantial, vast majority of users in both years, but rose from 79% to 91%. Okay, so in 2013, 91% of users used no out-of-network services. So those users are not even affected by what's going on, really. And then if you look at the, just as another statistic, if you look at the white bar, that's those are the small percent with the highest, with 100% or all of their services out of network. Very small segment, but fell from about 2 to 1%. And then about the proportion of users with more than half of payments for out-of-network services. And to get that, you would combine the white, gray, and the lightest purple. So that fell from 9 to 4%. So basically, any way you look at it, the proportion of users with out-of-network services is falling. I mean, I'm sort of saying the same thing over and over in different ways. And finally, the payer perspective. This chart shows us the out-of-network share of hospital-based services. And this is sort of a combination of type of service and site of care for hospital-based services and on-call specialists. And what we see, again, is the out-of-network share of hospital-based services fell from 2010 to 2013. The light blue bar is 2010. The purplish is 2013. It varied, as you can see, by type of service, site of care. The fall for critical care services was about 19%. The fall for anesthesia services was 65%, so that's pretty substantial, and all kinds of variation in between. You can also see on this the proportion of services in 2013 that were AOB if you look at the dark purple versus light purple proportion. And in general, that proportion, the AOB share, varied from about 70% to 93%, depending on the service. So again, it was very high. It was the vast majority of services were AOB. This is
so
sorry.
Just to be sure that when you made the point about cleaning up, getting the payers to flag the AOB, that the importance of them doing that is you could now make this very distinction that there, in some instances, a provider can opt not to go through with the AOB implementation, and the claim would then show up as not applying those rules. Right. Okay.
And this chart is very similar to the last one, but based on, instead of the share of at a service level, is total reimbursement, so the out-of-network share of total reimbursement. So we're looking at dollars here. Basically, it's a similar story, though, in the case of most services where there is a decline in the out-of-network share. For most of the services, critical care is the exception here, where it's pretty flat. There's very little change. But otherwise, we're essentially, again, seeing a decline in out-of-network share across these different types of services and sites of care. And we're not, I don't have any figures to present here, but again, just as a reminder, when we look at these by the major payers, the results vary quite a bit. And these changes vary quite a bit depending on the specific payer. So overall, in terms of the claims analysis, and I have a little bit more from the survey results to show you. The results, I think, I think they're pretty much what one might have anticipated. AOB, but I mean, I think they're kind of interesting. AOB seems to be a very popular option for those who elect to go out of network. I mean, it's very common. It's the vast majority of services. What happens because of this is that balance billing and the out-of-pocket burden have decreased for patients. I think that's pretty clear, and I think that was the intent, or much of the intent of the law. From the provider perspective, we see a decline in balance billing as a share of out-of-network payments, and the majority of out-of-network payments are AOB. That's sort of the same thing said in two different ways. On the payer perspective, there are shifts in network participation that sort of go in both direction, and the survey results will give us a little bit more insight there. So I'm going to share those with you, and then if you have more questions. So this is just a little, everything, most of what I've said so far has been from the claims analysis, and this is, as I said, a small survey that we conducted with MHCC to 5 major carriers. And we asked them about changes in their network size, because that's not something that we can measure directly. We can only look at certain kinds of statistics and infer things. But so we directly asked about changes in their network size for hospital-based providers and for on-call specialists. And then we asked them whether they thought those changes were due to the AOB legislation. One of the 5 payers reported substantial changes in their network size for both hospital-based and on-call providers. A second reported more modest changes for on-call specialists only. And the provider that reported the large changes basically said that it was their counter move to the AOB legislation. So they decided, because of the AOB legislation, that they would actively pursue expanding their network, and they were able to do that. They also pointed to some hospital consolidation going on. So hospital buying practices, which sort of, since the hospitals are generally in network, expand those networks. We also asked them about how they paid out-of-network providers before and after the legislation. It was kind of a little bit mixed. Pre-AOB, 3 of the payers said they paid, comparable charges in the geographic area. 1 said they paid billed charges, and 1 said a combined approach, which is basically they tried to pay comparable charges in the region, but often ended up paying billed charges. Post-AOB, and remember that the legislation is written such that payers are required to select the greater of the 2 options, so they're not really freely choosing one of the 2 options. For hospital-based providers, 3 of the payers pay 140% of the average contract rate 2 years prior, which is option number 1. And 2 payers pay billed charges, and I'll say a little bit more about that in a minute. For on-call providers, 2 payers, again, 140% of the average contract rate. 1 payer, the average historical rate inflated, and 2 payers that they generally paid billed charges. So summary, I'll speak to that just a little bit. The first point I'd make is we see no evidence of decline in network participation, which was the initial fear or cautionary note to this legislation, the concern that was raised. So we see no evidence of that. There is some perhaps consolidation of hospital and physician practices that is going on, either precipitated by this or just as an independent market activity. That's, but it is happening, and so this has had this sort of effect where we are not, but the bottom line is we're not seeing any decline in network participation. Some concern was raised by payers about the difference between the 2 payment options, and they might prefer to see 1 payment option. We expect that these 2 payment options the difference between them would decrease over time. And also, I would just mention that the payers that are paying billed charges under option 2 are paying a higher amount than they are required to by law, either for administrative simplicity or for whatever reason they choose, but it isn't. That is not strictly required by the law.
Could you just explain that, why that is, so all the commissioners understand that?
Why it's not required. So the law states, and it's slightly different for hospital-based providers and on-call specialists, but essentially there are two. The payers are required to pay the greater of two options. Option number one being 140% of the average contract rate 2 years prior, and option number two being an average historical contract rate that gets inflated by the economic and the MEI. The payers feel that option number one is a better deal for them, but some of them are the greater of those. If they've historically paid billed charges, option two will end up being the option that they're required to select. But that doesn't mean that going forward they're required to pay billed charges. It just means because they used to, they're funneled into option two. They could still be paying 140% of the historic contract rate, which, if inflated over time by the MEI, will not be increasing at a rapid rate, most likely. Did that help?
So is it fair to say, and let me test these three headlines,
Okay.
so you're saying that that the consumer financial burden of out-of-network decreased with aligned with the legislation's intent,
Mm-hmm.
that network participation did not decrease substantially as feared, and that there were no major unintended consequences of, sometimes you pass legislation and it has unintended consequences, nothing that you could sort of see from the data. Are those reasonable headlines?
I think those are reasonable headlines.
Other questions, comments?
I like your headlines. Thank you. Those are helpful. I know narrow networks aren't really taking off as much in Maryland, perhaps other places, but could that be one of the countervailing forces going forward? In other words, you've seen changes you described, but do you foresee any narrowing of networks creating a problem in the future here in Maryland?
No, I mean, I think that was the concern, and it is not borne out. We do not see that. Whether it's, and I'm not going, whether it's related to the AOB legislation or not, I don't know, but we do not see that.
Well, I think that Dr. Schur is correct that until recently, narrow network insurance products hadn't gained any traction. United this year came out with a narrow network product that did not include some of the major health systems in the state. That was sold in, I believe it's 8 counties currently, and will, unfortunately, Commissioner Flagg's not able to attend today because of a death in the family, but I think it'd be good to hear their input as they are a national payer, what their thoughts are on rolling out some of these products here in Maryland going forward.
So this is a report that goes where in January?
General Assembly.
It still goes back to the legislature. So will this be a similar situation where there's a cover letter from the commission? Yeah. The reason why I'm asking is because I really appreciate the way you summarized it, as opposed to the header on the slide here, which says mixed results. When mixed results, particularly as people had fears about what was happening with the legislation, it seems like the headlines really are they're not so mixed. I mean,
yeah, that's a very good point. I think the mixed part is actually that there was some evidence of decrease in out-of-network share, which is sort of a surprise, and it's very differential by payer. But you're absolutely
so that could bring
right.
us back to neutral. So that could bring us back to neutral.
Right. Oh, okay. So I just. Oh, you said mixed results.
Yeah. So, and I'm just thinking as it's characterized, it seems like we're either neutral and things seem fine, or actually there's some positive impact, particularly from the patient's perspective and from the provider's perspective.
We can be enthusiastic.
Well, I would rather have something like that be how it's characterized in terms of the cover letter.
And I'm trying to take the Commission's feedback in general, which is I'm sensing that when there's something that's going to the Annapolis, that we'd like to kind of align on the headlines for those who just do read the headlines, as opposed to the 15-page or 20-page report, which is great work. But and we'll try to figure out a process that everybody can see that.
So I think it's important for everyone to read the entire report. I think, right now I would say, grave fears don't materialize might be a better way to characterize it from a payer perspective, because this was a very hotly debated issue back in 2010. There were many individuals on an intellectual and emotional level that were heavily invested in this, and I think we have moved on in healthcare due to the passage of the ACA. But I think my own personal perspective is that these types of debates may not be altogether productive. And while we don't want to mislead any legislature, we want to characterize it appropriately and point to other options, particularly opportunities for collaboration between payers and providers that will be mutually beneficial and, most importantly, helpful to patients as well.
Very good. Thank you very much.
Thank you.
The next item on the agenda is a certificate of need for Seasons Hospice and Palliative Care of Maryland. Chairman Tanio is recusing himself on this agenda item, and he has asked me to chair the remainder of the meeting. Kevin McDonald, our Chief of Certificate of Need, will present the staff report and recommendation on the application filed by Seasons to increase its bed capacity by establishing a 12-bed general inpatient hospice unit at Sinai Hospital in Baltimore City. Kevin.
Thank you. A little bit of background. The applicant is Seasons Hospice and Palliative Care of Maryland, Incorporated. They have been providing services in Maryland since 2003. Currently licensed to operate as a general hospice in Anne Arundel, Baltimore, Carroll, Cecil, Harford, Howard, and Prince George's County, as well as the city of Baltimore. On a national level, Seasons began operating inpatient hospices in hospital space in 2003. Currently, they operate 5 such units, totaling 60 beds. 2 of those are currently in Maryland. One is a 14-bed unit at Northwest Hospital. The other, a 16-bed unit at MedStar Franklin Square Medical Center. Seasons has offered inpatient hospice at Sinai since July of 2011. That started out as offering hospice services on an as-needed basis in acute hospital beds. Subsequent to that, in 2012, Sinai Hospital built dedicated space or renovated dedicated hospice space for Seasons to provide services within the hospital. However, it was subsequently determined that by OHQC that contractual agreement was not compatible with licensing law in Maryland, which would require that the beds be licensed under the general hospice license of the hospice operating the unit. At that point, the unit was closed. However, Seasons again went back to the earlier model of offering services within the hospital beds, which resulted eventually in an application to expand their hospice bed capacity with a 12-bed unit in Sinai. The cost of that project was $1,388,372. Those renovations were completed. The money's already spent. It came mostly out of cash from Sinai Hospital with a contribution of a little under $80,000 by Seasons. In terms of need for the project, there's a projection of serving an average of 531 inpatient hospice patients in the first 3 years, which would be a 73% occupancy rate. The vast majority of those patients will be originating from Baltimore City and Baltimore County, and the projected source of those patients, more than 50% of those are projected to be patients that are in Sinai Hospital and otherwise would be expiring in a hospital bed, an acute hospital bed, rather than in a hospice bed. Another significant portion of those patients would likely shift from using the Seasons Hospice at Northwest Hospital to this one based on an analysis of the patient origin, with an assumption that most of the patients from Baltimore City would choose to, who opt for inpatient hospice, need inpatient hospice, would choose Sinai over Northwest based on geographic reasons. In looking at cost effectiveness and cost-effective alternatives, the cost to payers will not increase, as 85% of patients are Medicare patients for whom there's the same fixed level of payment regardless of where that occurs. Also, the placement of an inpatient hospice unit in a hospital would benefit patients by affording greater availability to a higher level acuity services for palliation and symptom management. There's also the belief that placement within a hospital would lead more patients and families to choose hospice care and more clinicians to be familiar with and recommend it, ultimately leading to a greater acceptance and use of hospice services. And finally, the preservation of capital would be a benefit, as the use of existing vacant space within a hospital is less costly than the cost of developing a new facility. Looking at the viability and financial feasibility, in terms of availability of resources to implement the project, that's kind of a moot point. It's already been implemented, so it's, those resources obviously demonstrated available. In terms of resources necessary to sustain the project, Seasons has total assets of $8.6 million against liabilities of about $3.3, total equity above $5 million, and show profitable operations in 2012, showing a net income of over $1.8 million on total service revenue of just under $25 million. And the financial projections for this proposed project show a positive bottom line from the inception of the project. In terms of impact on other providers, there appears to be a minimal impact there. Again, much of the expected volume would be coming by increasing the pool of hospice patients rather than drawing them from other facilities. Again, by having the availability within the hospital, more familiarity
and perhaps more confidence and comfort on the part of patients and families, more people would choose hospice services rather than dying in hospital beds. There's also the shift of about 100 patients from the hospice at Northwest Hospital, which is a seasons operation, and I think they believe that capacity would be backfilled, particularly with a population that they're, I think, currently having a difficult time finding space for, which is respite patients. This project actually was slated to be on the Commission's agenda back in July, at which point MHC staff had written a positive recommendation for the project, but had put a condition on the project, at which point the applicant asked to remove it from the agenda while they considered that condition. And that condition was that LifeBridge, the health system owning Sinai Hospital, would relinquish the hospice license for the Levendale facility, which historically had a hospice license back, I think, prior to the certificate of need, prior to the time that certificate of need was even in place, had not used that hospice license in a number of years, but it was continually being renewed and kept active, which led to some staff concern about the possibility that this could at some point lead to a duplication of services on that campus. After consideration and discussion, LifeBridge did agree to relinquish that license, and you have in the report a copy of the letter to OHQC offering that relinquishment. So it is based on staff opinion that this application meets the standards and criteria and recommends approval of the application.
Okay, thank you, Kevin. So
let me just tell you, representing Seasons today is Dean Foreman, the executive director for Seasons. Gary Applebaum, their national medical director. Joel Sullivan is here for a LifeBridge. Howard Solins and Jack Eller are here of Oberkaler, counsel to the applicant.
Okay. Thank you. Welcome. So is there a motion for this action in front of us? Motion, second? Okay. So questions, discussion? Any questions?
You make a distinction in your discussion about a hospital bed and a hospice bed. I'm going to ask a question like my mother would ask. We're in the same building, right? And so I guess my question has to do with, and I've read the report, but I'm really interested in, if I walk into the ICU, I know I'm in the ICU. If I walk onto the patient, as I move to the hospital, I have a different feel for where I am. When I move into the hospice wing of whatever this is going to be, how would I know I'm there? And how do you make sure that the patients don't assume they're not still in the hospital where interventions are going to happen for their loved one?
I think it's in the dedicated unit and the way it is redesigned to be much more home-like and to accommodate family participation. Not to say that can't happen, the family participation can't happen in a hospital room. Probably can't happen in the ICU. But I mean, that would be my answer, is the way the room is set up, outfitted, the decor, the feel. And if you'd like, we could have the applicant come up and maybe.
I only ask when a family says, I want to take my loved one into hospice, in the, say, the old model, either they're coming to my home, or I'm really like making a transition. And that's what I'm trying to pick up, how that happens in a setting like this. Given with some populations, particularly racial and ethnic minority populations, there's still hesitancy. So just, how do you change the culture in ways when you stay in the same facility and may see some of the same providers who used to be involved in life-saving now shifting to a different mode? You understand what I'm saying?
Yeah, yes, good. Excellent question. Gary Applebaum, National Medical Director, and I have the privilege of attending and caring for patients on our units. What you would notice would be a lack of beeping machines and a presence of people with guitars. What you would notice would be a ratio of one nurse to every 5 or 6 patients who really spent most of the time there. What you would notice occasionally would be 12 family members sleeping all over the room and being with the patients and holding their hands. And you would notice a place that is clearly structurally a hospital, but physically, spiritually, and in a feel another kind of place. And the patients who were there, who were competent, would sign a very lengthy technical document that makes it abundantly clear that they are choosing comfort measures over aggressive care. So there'd be no expectation that they would be rolled down to an MRI that they no longer would want anyway. And for patients that are not competent, their loved one, the power of attorney, would and we would have the counselor who sits with them for a good deal of time to make sure they have a very clear understanding. And generally speaking, it's what they want. It always is what they want and what they confirm by signing it. And I would invite anyone to come by and see the unit, and you'd realize that, yes, it's bricks and mortars, it's a hospital, and it meets all the codes and regs, but it's a different place. And much like the ER handles emergencies and delivery room delivers babies, there's now a place in that hospital that is very appropriate for people's final journey in a peaceful environment where things can progress the way they need to. So I hope that answers.
It does. I would find it fascinating to visit that you could create such a separation, which I think would be critically important.
Enormously important. Thank you. And thanks for the question.
Yes, I.
I'm very supportive of the increase in hospice services availability, particularly in Baltimore City, which has such a low utilization rate. The lengthy document is what caught my ear when you said that, because I was looking at the charity care and thinking about the poverty rate within Baltimore City, and if the charity care guidelines are built into the phrasing that was used in here, that it's part of the consent package, and if that's a very lengthy document, they may or may not see it, and I'm jumping to conclusions here. But I guess this is more of a request that they're, given the demographic of the city, that provision of charity care be a high priority.
As a matter of practice, we never turn down any patients for care, specifically those who are already in the hospital and in need of transferring. So we have a percentage of charity of unpaid services, and we've never looked at that when it comes to bringing them into our unit. So, and it is on the website.
Actually, your staff is exceedingly vigilant on the charity care policy and what it says and where you stay at, and making sure it's available on the website. And we had specific discussions.
So when rubber meets the road, we don't turn down patients.
I'll also say Seasons is very proud of its data on, compared to other hospices, on minority access, particularly experience in Baltimore City. As was indicated by Kevin, they have a history of providing services there. And Northwest is in Randallstown. It's a good, diverse area, and they have very good data on reaching out to full Baltimore City's metropolitan areas, full demographic reach.
Okay. Fran. Thank you for a very good presentation, and I recognize that this has sort of had a tortuous history. This months and months of on and off and on and off. Appreciate you coming back now. And my question is not so much about the CON history, but it's kind of a fundamental question that here we've got Sinai Hospital, nonprofit, identifies a wing or a unit that is appropriate for, there's a need for inpatient hospice. Seasons, as a proprietary corporation specialized in this care, comes in as the care provider to operate that unit, to not directly bill for it, because I guess the hospital bills and then reimburses.
They do bill.
Seasons directly bills. Okay, directly bill. Okay. So here's my basic question is, in that scenario, if I'm the hospital, I've put out this segment of my capital space to a tenant, so to speak. Why did Seasons, why did Sinai pay for the work to be done? Why was that?
Oh, because Seasons is leased.
Okay, so that didn't come. So that's why. So there's a lease agreement. There's a long-term lease agreement.
Yeah. There's a
Okay. That makes okay. Okay.
What originally happened, not to get too much, is there was a difference of views as to whether you could cluster hospital beds. And so when the money was spent, it was spent by Sinai because the thought was you could cluster it. Okay. So now what's happening is we've done what we were asked, closed the unit, applied, and now Seasons will pay back Sinai through the lease.
So that's ongoing revenue back to Sinai.
Exactly correct.
That. Okay.
Yep.
I got it. Thank you.
There's no further questions. All in favor, say aye.
Aye.
Opposed?
Aye.
You have your CON. Thank you. The next item on the agenda is upcoming initiatives, and Ben will provide us an overview.
For the record, we also want to thank Seasons and their counsel for attending the entire meeting today. We did alert them that because of a change in order that they would be appearing last, but they agreeably heard it all. So we have, as you heard, a couple reports that will come back to you in January. The AOB report will be presented for submission to the legislature, as well as the study on the freestanding medical facility. We'll also be considering an application from Aetna to establish a patient-centered medical home program in Maryland. We'll be looking at taking a vote from the commission to form a provider carrier work group that will be looking at issues that do not have specific authority in any state agency. This continues in a formal way a role that MHCC has played in the past, where we've taken on issues such as step therapy and tried to work on a solution that was agreeable to all parties, and then could be that type of debate could be removed from the legislature. We have a couple nursing home projects, the expansion at Rook Grove Nursing Home in Rockville, Maryland, and I think that concludes what we know right now. So it'll be a fairly busy meeting in January in anticipation of the start of the legislative session about the same time, the preceding day. So happy holidays to everyone, and that concludes my presentation.
Okay, no further business. I'll ask for motion to adjourn. Second. We're done. Happy holidays. Thank you.